Certainly our keynote speaker, our alumni, our faculty, and friends of faculty and alumni and foreign students. And I really have the opportunity to hear about important issues around healthcare, but more importantly, to come together as a community, the Bouvé College community, we all are. And I also want to take the opportunity today to welcome Susan Parish, who is our new Dean of the College of Health Sciences, Bouvé College of Health Sciences. And I say new Dean because it's been about 2 weeks that she's been with us. And so I welcome you to join us and welcome everybody. Thank you, Susan.
Thank you so much. It is just an absolute pleasure to be here tonight to welcome all of you, students, alumni, faculty, colleagues, families, and friends of Northeastern. We gather here tonight to hear from our distinguished guest and former colleague, John Auerbach, who will address some of the healthcare initiatives underway in this new administration. And he'll use this extraordinary venue to celebrate the 10-year anniversary of the Department of Health Sciences at Bouvé College. And I think we all need to give a round of applause to all of the faculty, and particularly to Steve Zoloff for his leadership in creating the Department of Health Sciences at Bouvé. During my extremely short tenure here at Bouvé, I have been so fortunate to meet with students and alumni and faculty, and what really has struck me, no matter which part of the college I have been visiting, whether it's pharmacy or nursing or health sciences or the other departments, it's the extraordinary commitment and passion of the people who are drawn to our college. And I have such a sense of faith and hope and optimism about the future of health, knowing the incredible students that we are training to become leaders. And Jean McGuire, during the little event we had across the way, she said, well, now that you're all here as alumni, I can retire. And I think we all can feel like we are in excellent hands, knowing that the future of healthcare leadership is with our students and our alumni. So I know that this topic of healthcare, it's at the forefront of everyone's mind, and we're so lucky to have John Auerbach with us tonight. And I just think that, you know, our timing on this could not have been perfect. I think you probably have been changing what you were going to say, depending on was there going to be a vote, wasn't there going to be
I may change it again.
Yes. Yeah. So just join me in this warm, wonderful evening and our lovely opportunity to celebrate 10 years of health. That's great. I love it when my students do that in class. When you don't get points, that wasn't a very good ringtone. Yeah. We gotta have a jazzier ringtone. But I'm delighted to welcome you, so thank you.
And I'd like to welcome Lindsay Weigel, who will be introducing our keynote speaker, and a little bit of yourself, maybe?
Good evening to all, and thank you for coming out tonight to help celebrate a time of major change. My name is Lindsay Weigel. It's so awesome seeing so many familiar faces, professors, faculty, classmates, former Pure Health Exchange members. I'm a medical student at Tufts University School of Medicine and a health science graduate from the class of 2015. I just completed my second year of didactics at Tufts, and I will be starting my medical clerkships in the spring to pursue becoming a physician. I'm here tonight to introduce one of the most influential individuals I was given the opportunity to work with at my time at Northeastern. But before I do that, I want to give a huge overarching thank you to the faculty of the Bouvé College of Health Sciences for helping each member of our student body achieve their own goals. Thank you, Bouvé, for introducing me to Pure Health Exchange, a program that allowed me to travel to public high schools throughout the city to teach health education. Thank you, Bouvé, for pushing me to participate in global health outreach. Working in Belize and Ghana enriched me. Thank you, Bouvé, for the co-op program. I was blessed with 2 incredibly engaging clinical experiences, which helped me make the decision to go to med school. And thank you, Bouvé, for helping me develop into the young professional I always dreamed of. I really could not have done it without you. I especially could not have done it without a man who's here with us tonight, John Auerbach. I had the pleasure of working as a teaching assistant for a course called Health in the City. We focused on the patterns and approaches to providing health care to underserved populations. During one class, we visited Boston Healthcare for the Homeless, a facility that provides care to our city's homeless population. I instantly fell in love with the mission and values of Boston Healthcare for the Homeless, and I told John that I wanted to co-op there. I told him that the night that we went there, even though they'd never had a health science co-op before. So, the night that we were there, John introduced me to the CEO of Boston Healthcare for the Homeless, Barry Bach, and I had a co-op by the end of the night. Since then, I've been working at Boston Healthcare for the Homeless ever since in many different positions, doing research with them, working as a medical assistant, helping with different sorts of projects with health education, and it's been very enriching. So not only has John Auerbach changed my life, but he has changed the lives of many throughout his time spent serving as the Commissioner of the Massachusetts Department of Health, Executive Director of the Boston Public Health Commission, Associate Director for Policy and Acting Director of the Office for State, Tribal, Local, and Territorial Support at the CDC, and now the President and CEO of the Trust for America's Health. John, you're a true innovator of public health, and I am honored to introduce you here tonight.
Thank you very much. I would say that working with Lindsay was a highlight of being a professor of practice at Northeastern. I would say working with Lindsay was like co-teaching the course because she was so amazing and just a natural instructor and incredibly knowledgeable. So it's terrific to hear about your experiences in medical school, and I know you'll be just amazingly successful. And that's my experience with the students at Northeastern has been uniformly positive. I've had incredible positive experiences with them. Nicole Bork is another example of someone who wasn't simply a student, but was also someone who was immediately interested in the community, the wider community, what could be done to improve the general health of the population. And when I left initially from Northeastern to take what was supposed to be a one-year leave of absence to work at the Centers for Disease Control, it was really by coincidence 3 former students at Northeastern, 2 of whom were employees of Northeastern at the time, and one of whom had just graduated from Sean Mohammed's Masters in Public Health program, also were hired by CDC. So we went there independently of each other. The 3 of them had applied, been accepted to work at CDC just as I was going into the program there. And then I would just tell you one other story. Once I got to CDC, I thought there were lots of students that CDC hires to work in its many different programs. There's 15,000 employees at CDC, and it's based all over the world. But, you know, and the students are great, so I don't want to disparage the students from other universities. But I was really struck in my first 6 months of working at CDC that the students that I was working with through internships really didn't have the same preparation and maturity and work ethic that the Northeastern students had. And so I suggested to the CDC that we start a special co-op program. And people said, oh, you know, we have, you know, lots and lots of students who are coming constantly to the CDC. So I said, let's try this. We'll try it with Northeastern. And so we hired our first co-op student, who is Christine Luong, who some of you may know, who's an amazing student in health sciences. And by the end of like 3 months, she was there for 6 months. Nobody believed she was an undergraduate. She was a sophomore at the time. People kept saying to me, when does she finish her doctorate program? And people kept saying to me, has anybody else already offered her a job? And I'd say, she's 19. So you can't hire her yet, because she has to go back and finish her undergraduate degree. But that was the caliber of the work that Christine represented. The next co-op student was a senior, and she had 2 courses to finish. She finished the co-op. She went back that summer to Northeastern to finish her 2 courses, and she was offered a job immediately. She didn't even have to apply. Based upon her 6 months in CDC, she was offered a job, and now works in the policy office. And I would say it's not easy to get a job at CDC. There's for a job opening, there's lots and lots of candidates. So I think that speaks to the caliber of the students here. But that's not what I was going to be talking about tonight. So I am going to be sharing with you, for stepping back a little bit and talking about what are the big trends that are shaping health and public health now. How are some of those trends likely to be affected by some of the changes in Washington? So I am going to go through some slides relatively quickly. I'm not going to tell you, I'm not going to tell you what Trust for America's Health is, other than to say that part of what we do is we're a nonprofit, nonpartisan organization, no government money. We're funded by foundations with long-term funding. And the goal is for us to be actively involved as an independent voice on health policy at the federal government level. And so we're very much involved in the deliberations now in Washington. This is a slide that I have to insert because I've only been in this new job for the last 2 months. So Dean, I really appreciate that you knew where you were tonight, because I wake up in the morning sometimes and I think I'm still at CDC in Atlanta, and you will hear that reflected in some of my conversation tonight where I say I'm really talking about work that I did at the Centers for Disease Control, and so just bear with me if it gets confusing as to what am I talking about? I'll try to clarify that. I want to begin by talking about the 5 major significant trends that I think are likely to shape the field of health and public health. And I think they're worth reflecting on because of the likelihood of their significance and the likelihood that they will continue even with the new administration. So the first one, the national trend that I would highlight, is increased access to care. And just to summarize what the outcome of the implementation of the Affordable Care Act is that it was a 20 million more people having insurance. And that significantly dropped that insurance rate in the country. Now it's about 10% uninsured in the country. And we saw increased access to insurance in every state in the nation, including those that didn't expand Medicaid. And that was because there were subsidized programs for low-income people, and because there were also exchanges that people could get onto and find out how to buy insurance. A number of states, people found out they were actually eligible for Medicaid. They didn't need expanded Medicaid. They were eligible and didn't know it before they checked. So some of the states with the biggest increases in the percentage of insured were actually states that didn't expand Medicaid, but had a very high percentage of uninsured before. Now, you probably have heard that in the effort to consider alternatives to the ACA, or the Affordable Care Act, there were proposals that involved cutting the number of insurance by what the Congressional Budget Office estimated would be 24 million people. That was a serious legislative proposal. Part of why it died, though, is that there were forces within the House of Representatives that were in opposition to the potential loss of people of their insurance, and people in the Senate, too, of both Republicans and Democrats. So probably, even if it had passed the House, there wouldn't have been enough votes in the Senate to pass a bill that would have resulted in millions of people losing insurance. I think that we can assume that we're going to see a relatively high level of insured, if not exactly where we are now, somewhat comparable to that. That would be my estimate, given what we're hearing in Washington in terms topics of the debates. You know, things change quickly, who knows, but at least that's the current read. That's significant for a number of reasons in terms of how healthcare is practiced. The second major trend is payment reform, and I won't go into a detailed description of how healthcare is reimbursed, but the big change that took place over the last 8 years is a dramatic acceleration of a process to move away from the traditional way that healthcare has been paid for, which is a fee for service. Every time you come in, a clinician gets paid for a unit of activity, to something called value-based contracting, where the goal is to reimburse in a more global way if there are positive outcomes. So instead of thinking of it as volume that drives what the revenue is that comes into healthcare, the idea is its quality, its outcome measures. So this value-based contracting is significant for a number of reasons. Among the reasons is it gives much greater flexibility in what you can do and, if you're a clinician and you're trying to meet the needs of your patients, and the traditional way of being paid for on a unit of service, a 15-minute visit or a laboratory test, may not capture what the patient needs. And we'll talk a bit about how what patients actually need, what we need as consumers in healthcare, doesn't always fit into what you can do in a brief clinical setting. Value-based contracting offers us opportunities. That's trend number 2. Trend number 3 is that there are emerging clinical models. And for the first time in American history, there is a preferred way to provide, official national preferred way to provide primary care, and that's through something called a patient-centered medical home, which is an accessible, comprehensive primary care site where you can get a lot of your needs met in a single accessible location. This chart shows 2 examples of organizational units that have been actively promoting patient-centered medical homes. On your left, this is the number of accountable care organizations. These are new organizations, those are comprehensive organizations, and they are now about 20 million people in the country get their care from accountable care organizations. On your right is the chart showing you the community health centers. So these are federally qualified and other community health centers where another 20 million people get their health insurance, their health care. So those are examples of locations where that kind of patient-centered medical home is available. The fourth trend is changing demographics. And this is this relates to the fact that our healthcare system, as well as our training programs and our public health system, don't always reflect the changing demographics of the country. One example of the way that they don't is indicated by that chart, which shows you the projected percentage, you see it going up rapidly, of the population that will be over 65. In many of our training programs, our clinical training programs and other training programs, geriatrics and elder health are not prioritized. In many of the programs, there's more of an emphasis on pediatrics, for example, or younger, or adults. If you talk to people who work in public health and you said to public health programs around the country, how many of you have specialized programs for people over 65? Virtually no hands would go up. Virtually none. There's virtually no public health activities that focus on dementia. There's virtually no public health programs that focus on sensory deprivation, like losing your hearing and eyesight. That's just one example of where the healthcare and public health systems and educational systems haven't necessarily recalibrated their emphasis to reflect changing demographics. And the changing demographics are also the more diverse race, ethnicity, language of the population, where there needs to be attention to that. That's trend number 4. And trend number 5 relates, the last trend I'm going to talk about, to the public health system that complements the healthcare system. And there, what we've seen is, over the last several years, a dramatic decrease in resources. We've seen a loss of an estimated 50,000 jobs since 2008, when there was the recession. Some jobs came back. A lot of jobs in public health didn't, an estimated 50,000. Public health has stepped back and thought about what it needs to do. This is at the local, state, and federal level, including CDC. And among the things that public health has done differently is public health has moved away from safety net provision of direct services. In many locations, since the early 1900s, public health would set up free safety net clinics in many locations. In some of those locations, there were no primary care providers. In places like Boston, the public health clinics would offer STD services or TB services, sometimes reproductive care or immunizations. In parts of the South, it almost becomes the primary care site. But as more people became insured in that first trend, and as more patient-centered medical homes became available, as more health centers opened and there was more of an effort to expand different ways of getting services, there has been a significant reduction of patients who would go to those safety net clinics. And by and large, public health has adjusted to that and said, let's take those resources that used to provide those clinics as patients now get those services somewhere else, and let's move what might be called upstream. Let's think about how we can change the conditions in people's lives, not through clinical care, but by focusing more and more on the conditions in the community. So I'll talk a bit more about that. But those are the 5 major trends we've really been tracking. When I was at CDC, we would track those, and I think that they are trends to pay attention to. But I want to step back. Those are big national trends. And so when we think, as we're developing policy in government, sometimes we can think globally and think at the 3,000-foot level and lose sight of the fact that what should be driving our development of policy should be the individual needs of the people in the country. And that when we think about implementing policy, we should be thinking, how is this going to directly affect some of the folks that are the most vulnerable? So let me introduce you to Miss Fran Edwards and give you a bit of her history. So she is one of those people one of those 20 million people. She didn't have health insurance. She works, but she's low income and her employer didn't provide it. She was able to purchase a subsidized insurance program off of the exchange in her state. And so for the first time in a number of years, instead of seeking her care in an emergency room when she got sick, she was able to get a primary care provider and get a lot of things taken care of. She's, as you can see, she's in her mid-50s and she's got some behavioral issues that put her at risk, and she's already got some health issues. So she smokes and she knows she shouldn't smoke. Her doctors have counseling her about that, trying to give her options to help her quit. She knows she needs to lose weight. She's just been diagnosed as pre-diabetic by her new primary care doctor, and she knows she's been asthmatic because that's what's prompted her emergency room visits in the past. So we're very happy about Ms. Edwards. The fact that she now can get proactive primary care and prevention, and she can get her medications for free that she needs, means that for the first time in years, instead of her waiting for something bad to happen, she can begin to get her health under control. So the question arises, have we optimized her health? Now that she's got the benefits that came along with the ACA, is that enough? Should we be happy and say, we're really pleased that she's in a better situation? And I would say, as a public health person, we shouldn't be. And she's gotten a necessary but insufficient service in order for her to be healthy. What she hasn't received is help in some other things in her life that also have a profound impact on her health. She is relatively low income. She's got 3 children. And she lives in a neighborhood that is an urban neighborhood, not so easy to walk around, not so safe. So she's listening to her doctor counsel her on exercise as a way of controlling her weight and the pre-diabetes, and she's thinking to herself, I work all day, I come home, I I need to put food on the table. I could go out after work and walk around the neighborhood with my girlfriends if I could, but it's not safe. It's not well lit. I'm not going to be able to do that. I don't have time or money to join a gym. So she agrees with her doctor she needs to exercise. She can't figure out how to fit it in. She'd like to have more fresh fruits and vegetables. Within an easy range of where she lives, there's not a store that sells fresh fruits and vegetables. She lives close to convenience stores. She'd have to take a bus to get to another neighborhood to shop. And she's worried about the prices of fresh fruits and vegetables relative to some foods that she can buy that are less healthy. So there too, she's listening to her doctor who's giving her great advice, but she can't follow through. She's under a lot of stress. She's got a son who's got some behavioral problems, substance abuse problems, and she's not sure he's going to get the care he needs. And she feels like worrying about her kids is connected to her smoking, because she feels like she'd like to stop smoking, and she feels like she can get there if she feels like she can get beyond some pressure in her life. And then finally, she lives in what might be called subpar housing, because there's some mold in her house. And so even though she's now taking her asthma medication, and that's helped her in terms of her asthma, the fact that she's living in a home where there are asthma triggers means she's still having symptoms. So what do we do? What do we do from a policy perspective? From a policy perspective, we'd say the ACA and the focus on health insurance and high quality care gets us some of the way, but it doesn't address these issues. And in CDC, what we found was that the problem was that we could talk about this, but it's not an easy conversation to have. It's not an easy conversation to have in part because there are often increasingly forums where health policy folks are drawing in insurers and healthcare providers and even public health people around a table to say, let's think about how to create the right conditions. What we found was people don't use language in the same way. They were finding they would go to public health people, would sometimes go to meetings with the large insurers, a governor would call a meeting, maybe it would have a large healthcare system. They'd be talking about prevention and population health, and everyone in the room would hear those words and be thinking of something different. The individual doctors or nurses would be thinking, you're talking about my patients, and you're talking about the patient that I want to either provide a vaccine for the flu, or maybe suggested that we should do a cancer screening. The insurers in the room are thinking about their premiums, their benefits coverage, and what packages they should be offering with what return on the investment. And the public health people are not thinking about patients, they're thinking about what do we do for people who live in the city or the whole state, and what are we doing about those folks? And there have been, in those meetings, a lot of miscommunication and sometimes actually disagreements about what's more important. Should we be working on quality care? Let's focus on that for a while. And other people saying, no, we should pass the right laws so that there's a ban on smoking in workplaces. Let's work on those. That's more important. At CDC, we decided we needed to focus on a number of different things. When we thought about Mrs. Edwards, we thought, here's the things we would design for her. We can check off that first one. She got the primary care meds at no cost. But what we thought she needed in terms of her asthma, in addition to her medication, was someone visiting her home. A community health worker is often a good person to do that, who's been trained, to do an assessment of the conditions in her home, to look for where there's dust or mold or other conditions, and to help to minimize those. There's something called the Diabetes Prevention Program that's been funded with grants from foundations and public health that offers lifestyle change classes at a YMCA and is oriented towards people with prediabetes who are low income and may not have time to join a gym. That program's been shown to be effective. She could benefit from that. Clearly, if she was in a center where someone was helping her think about how to get her son the behavioral health services, that would help. The neighborhood safety issue is important, affordable, healthy foods, etc., the mold in her apartment. To consider how best to achieve that, we developed this notion, the notion of 3 buckets. And our approach was to say, we need to work on prevention in multiple ways that are complementary at the same time. And each of these buckets needs to be addressed. If you're involved in healthcare delivery clinically and you're in one of these buckets, that's fine. But think about who's going to be doing the other aspects of the work. So let me tell you what each of the buckets represents. The first bucket, think of it as the traditional preventive services you get when you see a doctor or a nurse. This is what can often happen in a 15-minute visit. It's your flu shot. It's screening you for certain conditions. It may involve a blood test or a referral for something like a colonoscopy. Largely, these are reimbursable by fee-for-service, so they've been around a long time. So you might say, are we doing a good job with those? And the answer is pretty uneven in terms of how we're doing. Let me just see, I think I may have a slide. I don't on that one, but I'll give you some statistics. Most states vaccinate less than 50% of the people in the state who should get a flu vaccine. 50% of the people who have high blood pressure have their high blood pressure controlled by medication, even though virtually 100% can have their blood pressure controlled by medication. Only 2/3 of people who should get a colonoscopy get a colonoscopy. So there's a bunch of things that we know should happen that aren't happening. Many clinical practices think they're doing a good job on these issues, and when they get their data back, find out it's not as good as they thought, because it's hard to keep track of this. We think it's important to pay attention to incentivizing what we know works from a prevention perspective in primary care. How do you do that? Keeping in mind those 5 major trends. One way you can do it in a value-based contract for reimbursement is to create financial incentives for healthcare systems and clinicians to do certain things. So you might want to, what that may mean is there are 20 quality measures in a contract that a hospital or even a medical practice might have. And that the insurer says, unless you're doing a good job with those, you only get 99% of the reimbursement. If you want 100% or even more of that, you've got to show outstanding progress in meeting certain new quality measures. We're working with the insurers now to make sure that those quality measures prioritize evidence-based prevention services so that we can drive them up. I'll just give you one example of that. Remember I said 50% of the states, 50% of the people in the country with high blood pressure have their blood pressure controlled. That's pretty much true in every state except one, Minnesota. Minnesota, the people with high blood pressure, about 80% of the population has their blood pressure controlled. And we did a research study. We went to Minnesota. In fact, Christine Luong was part of this research program. And what we found was, what made the difference in Minnesota is the insurers and the providers got together and decided that part of the quality measures they all agreed to were screening for high blood pressure and taking certain steps to make sure people got their medication. And within 5 years, they drove those numbers that high. Now, that's totally replicable. And that's true for a number of these bucket 1 approaches. Insurance isn't the problem. Getting it to be a priority and paying attention to it is. At CDC, to help in terms of thinking about the ways to identify those evidence-based programs that work, we looked at all of the evidence and found that 18 of the preventive evidence-based programs in these 6 different health areas not only improved health in a relatively short amount of time, but also saved money in 5 years or less. Why is that important? That's important because the insurers are making benefits and decisions about what things to prioritize in those quality measures, looking at what keeps costs down as well as what has good health outcomes. So we wanted to demonstrate there really were things you could do as an insurer or a health system that would cut your costs in 5 years or less and have positive health outcomes. I won't go through the 18, but if you want to know what those are, cdc.gov/ type in the words 618. And there are 18 different evidence packages suitable to share with an actuary at an insurance company. This is one of the 18. One of the 18 was providing at no cost smoking cessation medications for patients using all of the FDA-approved smoking cessation products. You'd think that would be a sort of a basic service that would be provided, but the no-cost part of it is what often is the obstacle, as well as the option of all FDA-approved medications. In Massachusetts, when we made that service available, in 1 year, there was a 15% reduction in the people on Medicaid that smoked in 1 year. So we know that works, but it's not commonly practiced around the country. Bucket 2. So bucket 2 is the innovative services that are possible to pay for now because of that trend I was mentioning, moving towards value-based contracting. Innovative approaches consider whether a patient needs something other than what can take place in a clinical setting. So it includes things like that home visit I was describing for Miss Edwards, of a community health worker, of someone who could spend time coaching her in the home and eliminating with her some of the triggers to her asthma in the home. That can be paid for if you redesign your reimbursement system in a value-based contracting manner. Not so easy to pay for in fee-for-service. Another example, I think that's the example I highlighted here. Another example, though, is the diabetes prevention program, the program I mentioned to you before, that was that lifestyle change program, multi-session at YMCAs. The evidence was so strong that that worked for pre-diabetics that Medicaid and Medicare services, CMS, decided that starting in 2018, Medicare was going to pay for the diabetes prevention program. The first time they ever paid for a community-based service led by a non-clinician. But the evidence was strong. You can do that under value-based contracting. You can't do it so easily under fee-for-service because it's a visit to OY. There's no, it's not a clinical setting, it's not a clinician. With a value-based innovative approach, you can do that. There's some other ones too. People may have heard of a nurse-family partnership. That's a 3-year program of home visits by a nurse beginning when a woman is pregnant, particularly a woman with high-risk pregnancy. It's been shown to be very cost-effective in many different ways. So there are a number of those innovative approaches. Now is the moment for us to say, when we know something outside the box works in making someone healthy, let's try to get it reimbursed. So it's not just an isolated program that's funded by a foundation. It's something that we can increase for the whole population. There's real work to be done in bucket 2. And then bucket 3 is moving away from patients, and it's thinking about the community. It's thinking about the neighborhood, the city, the county, and the state. And if you can pass a law or a regulation or just make an administrative policy that makes something healthier. So what's an example of that? Well, we know that probably the most effective example of that is raising the price of cigarettes. If you increase the cost of cigarettes by a significant amount, usually it's 50 cents or $1 when that's done at a state level, you see a dramatic, statistically significant drop in smoking. It's evidence-based. You want people to stop smoking, charge $1 more for cigarettes, you'll see a reduction in smoking. It always works. It's been tried again and again. So that's an example of a bucket 3 approach we know works. We wanted, at CDC, we also wanted to know if there were other ones that we could say were sure things. Because when you're trying to pass a law or a regulation, particularly in the environment we're in now, where there's a strong anti-regulation approach, and people are worried about nanny state accusations, you want to make sure that if a governor or a mayor or an elected official is going to support something, there's real evidence that it's going to work. And it's going to work not in a generation or 10 years. Sometimes that's what you need. But if you're an elected official, a lot of the time, you want something that's going to work by the time you run for office the next time, so you can point to it. So we did an analysis of what laws, regulations, and global policies resulted in improved health in 5 years or less, and also reduced costs. And we didn't know if we'd find any, because there's a lot of things you should do that you don't save money, but it's the right thing to do. But what we found was that in a thorough examination of the data, that there were 14 well-studied, solid methodological evidence interventions that worked at a state, city, or county level. You do these, like raising the taxes on cigarettes, you get the results. These have two different kinds of, we broke these into two different categories. One category in the blue are things that you may have already heard of and thought, well, those probably do result in improved health. And those include things like the tobacco control interventions, like the taxes and also smoking bans. They include access to clean needles, that's needle exchange, also pharmacy sales of hypodermic needles, motorcycle helmets. So there's some things there that we can honestly now say they don't just work, they work in 5 years or less. If you want to convince your governor or mayor, you can point to this, and they all have evidence of cost savings. What we were surprised at in looking at the research, we didn't do any original research, we just did a thorough examination of the research that existed, was that there were also these programs that are not all traditionally thought of as public health. Most of them deal with things that happen in other sectors. But there was solid evidence that if you paid attention to early childhood education, the study there the studies that we saw focused on children 3 to 4 years of age, you get improved health in 5 years or less, and you save money. There was a diesel fuel years, health improves, and you save money. Some things related to income. We found that solid evidence that if you have programs that with earned income tax credits, you also get that improvement in health. Now there were and then there were low-income housing loans to make home improvements. Now we were actually surprised at those, that there was that solid evidence. Those are not small studies with a tiny sample. This is usually multiple studies with enough evidence so that the CDC scientific team of people who review research said, we can confirm this is real. Now, the reason that matters is we want to make the case that these things work. It matters in an environment like the one we're in now, where we're looking at some of those policies in red and trying to think about how they relate to the insurance coverage issue. And people have said to us, now the work that I'm describing to you is work that was done largely at CDC, but it's really done with lots of different partner organizations around the country. And so many people say, well, okay, you did that. You did that 3-bucket approach, and you came up with these initiatives like 618, and the High Five was the name of that, the policy-related initiative. Are those still relevant now? Can you do those things in a Trump administration or more conservative Congress era? And we've tested that out. We've gone to both community meetings in red states as well as blue, and basically talked through these issues in crowds like one here, and found, independent of red state and blue, people think those things matter and have been supportive. The organization that I oversee now is a nonpartisan, nonprofit, I think I mentioned. And so we also, just 10 days ago, convened a invitation-only meeting of 28 public health and healthcare leaders across the country, where we specifically invited people that represented every political view along the spectrum. We included within the invitees people who are in the final stages of interviewing for significant policy roles in the Trump administration. On the one end of the spectrum and maybe on the other end of the spectrum, we invited people who wanted nothing to do with the Trump administration and were leading the demonstrations against it, and all along the spectrum. And what we found in that meeting, we closed the doors and we served really delicious food, because we thought if we served delicious food, maybe people would be less likely to yell at each other. And I started the meeting as like I was running a third grade class. You know, I said to people, you know, there is to be no insulting here. There is to be no yelling, no eye rolling, and your job is not to convince the person that you disagree with that they're wrong. You can say exactly what you think, but your main job is listening to the other person. And we kind of went through the discussion and found enormous solidarity in terms of the basics. We avoided the third rails. We didn't talk about, is the ACA ideal? Should it be replaced? What are the ways of improving that? We didn't talk about that. We did find a consensus among the folks in the room that insurance coverage was good and that you should try to insure as many people as possible, that preventive services were key, and again, that you needed to work in those three different areas, driven by what you knew worked from a practical perspective, and where you could say, this improved health and it also was good for the economy. It wasn't excessively expensive. So we think that for us, we said, it's good to know. There are times when those people we had in the room will disagree with each other, that's fine. But we wanted to see, is there some sense of a consensus if you get people who normally don't talk to each other in a room where you can talk about where there's areas of commonality. And so as an organization, we're probably going to hold a number of those on different issues and see if we can develop action steps that come out of it. Now, this does give you some sense of what the third rails are. The blue line represents the percentage of uninsured that are projected to exist under the ACA, or what's referred to as Obamacare. It's about 10% now uninsured in the country, and it's projected that it would stay roughly about 10% over time. The House bill that was under consideration, the one where the Congressional Budget Office projected that 24 million people would lose their insurance, is represented by the red line. This is data from the Congressional Budget Office, by the way. And there the expectation was we'd start out at about the same place, but that we'd have about 19% of the population uninsured within a 10-year period. So again, that bill didn't pass. The House leadership are still talking about the possibility of coming back at some point with a revision of that bill. So we could well be talking about that, a very significant difference again. Our read of the situation in Washington is that there probably won't be another bill that's filed in the current session. It may not even be filed before the calendar year, but you know, we've all learned that the traditional way of estimating what will happen and projecting policy approaches is a little unconventional now. So take that with a grain of salt. But our latest discussions with folks in the legislature is they're going to move on for a while, and so this percentages may continue at least for a good part of the remainder of the year. We also do think, though, that it's worth taking a look at another aspect of federal policy, and that's not changing laws, but it's what's in the budget. So you may all have heard that President Trump presented a preliminary budget with no details, kind of what's called a skinny budget, because it gives you just an overview of what the initial proposal is from the president. And it had notably very significant cuts in every area except the military. And so from a health perspective, as a nonpartisan organization, we're concerned about that. one reason we're concerned is that the Health and Human Services Agency is, that includes the CDC and Health Resources and Services Administration, Substance Abuse Mental Health Services Act, and the CMS are all part of a secretariat with very significant cuts. There was no detail about how at the secretariat level they divide those cuts up. So it may well be that some agencies would be cut just a little and other agencies in the Health and Human Services arena would be cut a lot. But the expectation is that maybe that will be a relatively level cut. It may be something like 18% across all those agencies. 18% is a big cut. If you start cutting Health and Human Services agencies by 18%, you're eliminating programs we've taken for granted. And there may be some that are specifically targeted because they are not particularly popular with the administration. And those may include reproductive services, they may include global health. We saw even HIV was being cut in a little bit, an additional budget that the president submitted. So that's an area where we want to pay attention, where we just want to not pay a lot of attention to that. I encourage you to do that. And we will we'll be working at the organization I'm in. But but I'd also point out that there are other agencies, other secretariats where the significant cut could also take place, including, for example, the Environmental Protection Agency, where there was a recommendation of 31% reduction, in the transportation, 13%, where's HUD, housing and
Autumn Center.
oh, here, right, 13%. So again, why do those matter? Those matter because when we think about Mrs. Edwards, the conditions in her community are likely to have as big an impact, if not more, on her health. And so if there's less money for housing, there's less money for programs like low-income housing programs like the one that I pointed to, a policy program that we know improves health, or if transportation programs scale back on pedestrian or bike-oriented transportation projects, or if we don't have protections that allow us to assume we'll have clean air and water. Those are obviously problematic. So this is my last slide. And this just goes back again to thinking about where we need to pay attention in the coming year. As we think about the issues for Ms. Edwards, in terms of the primary care and meds, for the time being we may be okay. For the time being it seems the ACA repeal hasn't occurred, and so we're not worried about that, but there are some things that can be done administratively within Health and Human Services that may result in costs associated with, if you have a prescription and you need to fill it, it may not be no cost. There may be increases in terms of the co-pays, or the such things as saying all FDA drugs instead of just one FDA drug for smoking cessation. Those are administrative decisions that can be made and may be made by the administration. We still are seeing value-based contracting likely in the Trump administration. It looks that will continue in CMS, and so there are programs like the asthma home visits and diabetes prevention program may in fact continue, and there's talk about giving states more creativity in terms of coming up with programs. So those may be ones we should pay attention to. Behavioral health services was one I flagged for you as a concern. There's a lot of talk about the importance of supporting behavioral health, but within the bill that was considered in the House, a provision of that cut the requirement that behavioral health services needed to be a component of insurance. So that was an indication that there's no guarantee that in spite of saying it's important, the policy decisions may cut that. Neighborhood safety may be affected by the HUD cuts, as may be access to affordable food. There's something called the Community Development Block Grants through HUD that pay for programs that are useful in terms of community safety and community access to services. And the same thing's true with something like mold removal. So I'd say, you know, we need to keep our eye on how the policies are going to have a direct impact on someone like Ms. Edwards. We need to think about starting from the needs of the patient population that's particularly vulnerable, and how we can build policies that make a difference in terms of their lives. And I think that's going to be the challenge